Waking up in the post-anesthesia care unit, or PACU, is a physiologically chaotic process. It is common for patients emerging from general anesthesia to exhibit severe agitation or intense shivering as their bodies clear the pharmacological agents. When a patient thrashes in bed or fails to wake up on schedule, clinical providers typically default to one of two standard diagnostic assumptions: emergence delirium or residual sedation. But when a patient arrives in the recovery day with a known history of epilepsy, those default assumptions become dangerous. In this specific population, any abnormal movement or delayed awakening must be treated as an active seizure until proven otherwise. This diagram maps the overlapping behavioral symptoms of expected recovery against a hidden neurological threat, non-convulsive status epilepticus, or NCSE. NCSE is a dangerous state of continuous seizure activity occurring without the obvious violent convulsions of a typical seizure. If providers anchor on the idea that delayed awakening is simply residual anesthesia, they actively mask life-threatening events while the brain continues seizing. To navigate this diagnostic minefield, clinical teams rely on a strict set of protocols, the PACU Seizure Monitoring Checklist. Executing this checklist requires optimizing the patient's physiological threshold, differentiating true neurological deficits from routine recovery, and deploying targeted pharmacological rescue. Safely managing a seizure patient in the PACU means completely abandoning standard postoperative assumptions in favor of active, proactive seizure surveillance. Effective PACU management for these patients begins before they even clear the operating room doors. The anesthesia handover must explicitly detail the patient's baseline neurological status and the exact date and time of their last seizure. The receiving nurse needs the exact name, dose, and timing of the patient's chronic anti-epileptic drugs, or AEDs. This includes identifying the specific epilepsy variant. For example, a diagnosis of juvenile myoclonic epilepsy, or JME, a syndrome characterized by brief, involuntary muscle twitches, acts as a critical modifier that changes which rescue drugs are safe to use. The team also needs to identify intraoperative pharmacological variables, specifically noting whether benzodiazepines were administered during the surgery. The handover must highlight any exposure to proconvulsant analgesics. Tramadol, for instance, is a commonly used pain medication that actively lowers the seizure threshold. Finally, providers must check for any intraoperative metabolic or electrolyte abnormalities, such as hyponatremia, a condition of low sodium in the blood that can trigger seizures independently. A rigorous handover provides the exact baseline parameters required to identify subtle deviations and prevent an imminent collapse of the patient's seizure threshold. Upon arrival in the PACU, the first 30 to 60 minutes represent a period of high physiological volatility. This animated gauge illustrates the patient's seizure threshold. To artificially support this baseline and maintain cerebral perfusion, the clinical team actively manipulates systemic inputs like oxygenation, CO2, blood pressure, and temperature. The immediate airway and ventilation priorities require keeping blood oxygen saturation, or SpO2, at or above 94%, while enforcing strict normocapnia, maintaining normal carbon dioxide levels in the blood. Avoiding hypercarbia, or excess carbon dioxide, is crucial because high CO2 dilates blood vessels in the brain, causing physiological shifts that can directly trigger a seizure. Hemodynamic goals follow a similar logic. The clinical team must absolutely avoid hypotension, or abnormally low blood pressure, to ensure adequate cerebral perfusion pressure is maintained. Conversely, any postoperative hypertension or agitation must be treated aggressively and early to prevent excessive metabolic demand on the brain. Finally, the team must maintain strict normothermia, keeping the patient's core body temperature in a normal range. Stabilizing these core physiological metrics is active foundational seizure prophylaxis. With the physiological monitor stabilized, the team's focus shifts to continuous, active observation of the patient's physical behavior. This requires a rigorous level of consciousness, or LOC, assessment every 15 to 30 minutes. The assessment tests following commands, orientation to person, place, time, and symmetric motor responses. This split-screen matrix contrasts the visual signs of expected emergence on the left with targeted seizure red flags on the right. Non-convulsive seizures often present with incredibly subtle indicators: blank staring spells, brief periods of unresponsiveness, lip smacking, or repetitive chewing motions. More overt physical signs include recurrent stereotyped movements and myoclonic jerks, brief shock-like involuntary muscle contractions. The critical diagnostic challenge here is distinguishing these pathological myoclonic jerks from routine post-anesthetic shivering, which is a common byproduct of the body rewarming. The ultimate red flag during this observation period is a failure to awaken and return to baseline mental status along the expected pharmacokinetic timeline of the anesthetics used. If a patient fails to awaken as expected, the strict rule is to suspect non-convulsive status epilepticus immediately. Emergence delirium should never be the default diagnosis. Recognizing these incredibly subtle physical and behavioral cues is the only way to catch NCSE before prolonged electrical activity causes irreversible neurological damage. Once physiological and neurological baselines are established, the focus narrows to the immediate pharmacological needs of the patient. The highest pharmacological priority is the rapid resumption of the patient's oral anti-epileptic drugs. If the patient is NPO, meaning nothing by mouth, the team must ensure the precise intravenous equivalent of their chronic AED is running immediately. This decision tree maps out the danger of medication mismatch. Depending on the specific epilepsy subtype identified during the handover, certain standard drugs can actually exacerbate the condition. For example, there is a strict rule to avoid administering phenytoin and carbamazepine in patients diagnosed with juvenile myoclonic epilepsy, as these specific drugs can worsen their seizures. Postoperative analgesia presents a dual-edged sword. Inadequate pain control increases physiological stress and seizure risk, but certain pain medications are inherently epileptogenic. In this patient population, the strict do not use list for analgesics includes tramadol and meperidine. Providers must use other opioids judiciously to manage pain, while ensuring that rescue benzodiazepines are immediately drawn up and available at the bedside. Administering the exact right AEDs while aggressively withholding dangerous analgesics forms the critical chemical defense against a postoperative seizure. Even with optimal physiological and pharmacological management, the clinical team must be prepared for the worst-case scenario, a breakthrough clinical or subclinical seizure. This is the mandatory 5-step seizure action plan that must be executed the moment a seizure is suspected. Step 1. Immediately secure the patient's airway and administer 100% oxygen. Step 2 requires aborting the active seizure, utilizing intravenous midazolam at a dose of 0.05 to 0.1 milligrams per kilogram. Step 3 is loading IV anti-epileptic drugs to prevent recurrence. This typically involves levetiracetam at a dose of 1 to 3 grams, or valproate if clinically appropriate. Steps 4 and 5 trigger immediate anesthesia and neurology consults and initiate an evaluation for intensive care unit admission. Once acute crisis management concludes, the team must make a final disposition decision regarding the patient's required level of post-PACU care. Elevated care in an ICU or step-down unit is absolutely mandated if the patient experiences any seizure in the PACU, had a pre-op seizure within the last 2 weeks, displays prolonged altered consciousness, or has a history of status epilepticus. In the post-anesthesia care unit, any abnormal movement or delayed awakening in a patient with a seizure history equals a seizure until proven otherwise. Guard the threshold and escalate early.